Hi friends, this is Dr. Santosh Patil here, and in this video we're going to study about hereditary angioedema. Hereditary angioedema is an autosomal dominant, fully penetrant condition characterized by repeated episodes of angioedema. These angioedema episodes typically affect lips, then other parts of the face like area around the eyes. It can also affect the mucosa, and because of that, patients may develop laryngeal edema. It is not uncommon to see patients developing bowel wall edema and as well as edema of the genitalia. Okay. There are three types of hereditary angioedema. The first one is type 1, which is caused by deficiency of C1 inhibitor. Okay. The second one is caused by dysfunctional C1 inhibitor. The third one is not related to C1 inhibitor. It is due to mutation in factor 12. Yes, the factor involved in coagulation cascade, the factor 12 mutations are responsible for type 3. Type 1 is due to mutation in SERPIN G1 gene. So you might have heard of SERPIN very frequently in medicine. One SERPIN that you can easily recollect is what you see in patients with alpha-1 antitrypsin deficiency, where you see mutation in SERPIN A1 gene. Okay. So here it is SERPIN G1. SERPINs basically code for serine proteases, serine protease class of proteins or enzymes, and mutation in SERPIN G1 is responsible for type 1 hereditary angioedema. So this mutation is inherited as an autosomal dominant condition with full penetrance. That means it is passed on to every next generation of the offsprings. And third point you should remember about type 1 is this is the most common type of hereditary angioedema, and this accounts for more than 85% of all cases of hereditary angioedema. As I told you, the type 2 is because of dysfunctional C1 inhibitor. The mutation responsible for this is it involves the same SERPIN G1 gene. The difference between type 1 and type 2 is the type 1 mutations lead to quantitative defect. So in the sense, the amount of C1 inhibitor produced is low. On the other hand, in type 2, it is a qualitative defect where the amount of C1 inhibitor produced is normal, but functionally this is inefficient or dysfunctional. This is also inherited as an autosomal dominant condition with full penetrance. Though various modes of inheritance have been described with type 3, few authors have described X-linked dominant inheritance. Few have described recessive inheritance. And there are several studies documenting factor 12 mutations inherited as an autosomal dominant condition. Okay. But overall, all the three conditions or all the three types often have a strong family history, especially type 1 and type 2 because of a fully penetrant autosomal dominant mutations. When do we suspect that a patient presenting with repeated angioedema is actually having hereditary angioedema? The three important pointers in patients' physical examination and history which makes us strongly suspect the possibility of hereditary angioedema. The first one, okay, for any patient presenting with repeated episodes of angioedema, look for family history. In any patient with hereditary angioedema, the family history will be pretty strong because of the mutations which are fully penetrant. Second, these patients do not have pruritus or urticarial lesions. The absence of pruritus or urticarial lesions is typical of angioedema caused by bradykinin pathway. So there are two conditions where the bradykinin pathway is involved in development of angioedema. The first one is hereditary angioedema and the second one is ACE inhibitor induced angioedema. Then third important pointer for us to consider HAE is recurrent GI colics. So in the very beginning of the video, I told that these patients have a tendency to develop bowel wall edema also, and that bowel wall edema explains the recurrent GI colics that we see in these patients. A laboratory diagnosis is mainly by demonstration of either deficiency of C1 inhibitor or dysfunctional C1 inhibitor by catalytic inhibition assay. Okay, so for the dysfunctional C1 inhibitors, the demonstration is by catalytic inhibition assay. This flowchart talks about the approach to any patient presenting with angioedema without urticaria. So I just told you that this is possible in two conditions. One, either they have hereditary angioedema, or the second possibility is that they have ACE inhibitors induced angioedema. Okay. So basically these two are bradykinin related angioedemas. So the normal approach talks about first checking the C4 levels. The complement C4 can either be normal or reduced. When the complement C4 is normal, there are two possibilities. See, I told you that in type 3, there is normal complement level. So it's either type 3 hereditary angioedema or it is medication induced or ACE inhibitor or NSAID induced. There is also a rare possibility of idiopathic angioedema. I'll talk about it in a bit. What helps us differentiate between these two is obviously the history of exposure to the drugs known to cause medication-induced angioedema. If there is no such history, or if you're ruled out the culprit medication and also have a strong family history, then we consider type 3. In the absence of family history, if there is medication history, obviously the possibility of medication-induced angioedema comes into picture. On the other hand, medication history is ruled out. There is no family history, but patient comes with angioedema without urticaria, then the possibility of idiopathic angioedema should be considered. And this idiopathic angioedema is often associated with one, autoimmune diseases, and second is also associated with malignancies, mainly B-cell lymphomas. Moving on to this side of the flow chart, when the C4 levels are decreased, then there is possibility that patient either has type 1 or type 2 hereditary angioedema. When C4 is decreased and it is also associated with decreased C1 inhibitor levels, then look for the family history. If it is present, then we have a diagnosis of type 1 hereditary angioedema. Okay. On the other hand, if there is no family history, there is a possibility that patient has acquired mutations in SERPING1 gene. And for confirmation, we can definitely do genetic studies, but also demonstrate that patient has reduced C1q levels, and you can consider acquired angioedema. If the C4 is reduced, but C1 inhibitor levels are normal, then demonstrate that C1 inhibitor function is reduced by catalytic inhibition assay. And if you can do that, then go for the diagnosis of hereditary angioedema type 2. After the approach, let us look into few key points which are important from entrance perspective. What happens to complement profile in a patient with hereditary angioedema? C4, as we all know, it's now reduced. These patients also have reduced C2 but normal C1. So if you face any question which is asking you which of the following component of complement cascade is normal in a patient with hereditary angioedema, the answer shouldn't be C4, shouldn't be C2, and if C1 is an option, it should be the answer. What happens to type 3? Obviously, it is not related to C1 inhibitor deficiency or dysfunction. It is because of the mutation of factor 12, and hence the complement levels in these patients are normal. This question is essentially asking the same fact. Which of the following hereditary angioedema is associated with normal complement level? The answer is obviously type 3. This question is something interesting. It says, a child presented with angioedema. He has history of similar episodes in the past. His father has similar illness. On examination, his physician notes a rash. The image is given here and is asking what is the diagnosis. So let me draw your attention. There is a possibility that this patient has hereditary angioedema or allergic angioedema. Because he has angioedema, there are repeated episodes. But keep in mind that his father has similar illness. So there is some degree of family history. But he has developed a rash. The rash kind of looks like an urticarial rash. So what is the diagnosis that you're thinking of? If you're thinking of the diagnosis as allergic angioedema, you are wrong. I'll tell you why. First thing, the rash that is described, that is shown in the image, though it looks like urticaria, nowhere in the question I have mentioned that patient has pruritus. That means assume, because I'm not talking about pruritus, if patient had pruritus, it's such a predominant symptom that examiner would mention it clearly. So since it is not mentioned, assume that there is no pruritus. So prurite is not there, then this rash becomes little less likely to be urticarial rash. So what is this rash? This is basically the rash we see in erythema marginatum. So this is erythema marginatum rash. In which condition you see erythema marginatum rash? Yes, you see erythema marginatum rash in patients with rheumatic fever. Though it is very rare finding in patients with rheumatic fever, it is one of the major criteria for diagnosis of rheumatic fever, if you remember the revised Jones criteria. So this is one of the major criteria. But second most common reason for someone to develop erythema marginatum is hereditary angioedema type 1. Yes, this is our answer in this question. Remember, another important cause for erythema marginatum, if there is a question asking which of the following is an infectious cause for erythema marginatum, that is psittacosis. So 3 important reasons you should remember. Obviously, the first one, rheumatic fever. Second is hereditary angioedema, specifically type 1. And third is psittacosis. Now let us look into the management. 2 things become important for management because this is a very recurrent problem. We need to manage the acute attacks efficiently, but we also need some effective interventions to prevent repeated episodes. So the first and well-proven strategy is to infuse C1 inhibitor, either isolated from human plasma or recombinant synthetic C1 inhibitor. This can be used for both prophylaxis as well as for treatment of acute attacks. The second important drug is icatibant. This is an inhibitor of bradykinin 2 receptors. The third, ecallantide. Inadvertently, I have added an N here. There is no N. It's ecallantide, which is a kallikrein inhibitor. Both icatibant and ecallantide are approved for management of acute attacks of hereditary angioedema. You may get confused between icatibant and ecallantide. Icatibant has B for bradykinin 2 receptors and kallantide has kallikrein. Kallantide has Cal. That way you can remember which one is against bradykinin 2 receptors and which one is against kallikrein. With the hope that we may be able to replenish C1 inhibitors to a patient with hereditary angioedema, FFPs can also be given for management of acute attacks. Attenuated androgens like danazol can be used to treat, mainly for prophylaxis of hereditary angioedema. Epsilon aminocaproic acid is mainly used for pre-surgical prophylaxis. Surgical trauma is considered as an important precipitating event for angioedema in these patients, and hence this drug can be used as a pre-surgical prophylaxis. Remember, attenuated androgens and infusion of C1 inhibitor is also an effective strategy for pre-surgical prophylaxis, but we also have an additional drug, epsilon aminocaproic acid, in our armamentarium. Apart from these drugs, there are 2 new drugs which are very important from exams perspective. The first one is lanadelumab. This is a monoclonal antibody against plasma kallikrein, and this is FDA approved, obviously US FDA approved for prophylaxis of hereditary angioedema. The approved dose is subcutaneous 300 milligrams once in 2 weeks. So this is the first monoclonal antibody approved for prophylaxis. We have another drug called berotralstat. Berotralstat. This is the first oral drug approved for prophylaxis. Right now, there is no monoclonal antibody which has passed the trial stage and is into clinical practice for acute attacks. But for prophylaxis, we have lanadelumab, and we also have an oral drug called berotralstat. I think that's kind of covers all that you need to know for your NEET super specialty exam. I'll see you on another video with another interesting topic.